Welcome to another episode from the Veterinary Medicine Digest. Today we are embarking on an extensive exploration of a sophisticated surgical advancement in the treatment of canine spinal disease known as biportal endoscopic foraminotomy of the 7th lumbar and 1st sacral neuroforamen. This procedure represents a significant leap forward in minimally invasive veterinary neurosurgery, but to truly appreciate its value, we must first understand the complex landscape of the condition it aims to treat. Degenerative lumbosacral stenosis is a common and often debilitating disorder seen primarily in large breed dogs. Over the last 4 decades, this clinical entity has been described by various names, including Cauda equina syndrome, lumbosacral instability, and lumbosacral disease. Regardless of the terminology used, it refers to a multifactorial degenerative disorder where the degeneration of the intervertebral disc plays a central role. The progression of this disease involves bony and soft tissue proliferations that contribute to spinal stenosis and the compression of the cauda equina, ultimately leading to significant pain, lameness, and a variety of neurologic signs. Interestingly, the biomechanics and pathogenesis of lumbar disc herniation are remarkably similar between dogs and humans, allowing veterinary medicine to draw heavily from human medical studies to improve our understanding of this condition. To understand the pathology, we must first look at the unique clinical anatomy of the lumbosacral region. During embryonic development, the spinal cord and the vertebral column grow at different rates, which results in the spinal column being longer than the spinal cord in the newborn animal. In most dogs, the conus medullaris, which is the end point of the spinal cord, is located in the caudal half of the 6th lumbar vertebra or the cranial part of the 7th lumbar vertebra. The cauda equina itself originates from this conus medullaris and is composed of several spinal nerves, ranging from the 6th lumbar to the 5th coccygeal nerves. Surrounding this delicate nerve bundle are several vital structures, including the 7th lumbar and 1st sacral intervertebral disc ventrally, the pedicles and intervertebral foramina laterally, and the interarcuate ligament and vertebral laminae dorsally. The 7th lumbar and 1st sacral vertebrae are connected and stabilized by a complex network of synovial facet joints, the ventral and dorsal longitudinal ligaments, the interarcuate ligament, and the interspinous ligament. The intervertebral disc itself is a remarkable structure, featuring a triangular appearance on a lateral view and consisting of 3 distinct parts: the annulus fibrosus, which provides tensile strength, the gelatinous nucleus pulposus, which acts as a shock absorber, and the cartilaginous end plate, which functions as a semi-permeable membrane for nutrient exchange. The pathogenesis of degenerative lumbosacral stenosis is often a negative spiral initiated by abnormal motion patterns at the lumbosacral junction, which may be caused by repetitive stress or genetic predispositions. As the intervertebral disc begins to degenerate, there is a degradation of proteoglycans, which leads to dehydration and a loss of disc width. This instability shifts the load bearing of the spinal segment from the central axis of the disc to the peripheral parts of the spine, such as the facet joints and the ventral aspect of the vertebral bodies. To compensate for this increasing instability, the body undergoes a proliferation of soft tissue structures, resulting in the hypertrophy of the interarcuate ligament and the development of epidural fibrosis. Furthermore, bony proliferations such as osteophytes and spondylosis develop, which further impairs the nutritional supply to the disc. This process culminates in the narrowing of the intervertebral disc width and the bulging of the annulus fibrosus, often leading to what is known as Hansen type 2 disc herniation. These changes result in the stenosis of the spinal canal and the compression of the cauda equina or its blood supply, causing the clinical signs we observe in our patients. The epidemiology of this condition shows a strong predisposition for large breed dogs, particularly the German Shepherd dog and various working dogs. Data from extensive insurance studies in Sweden suggest that the incidence of degenerative lumbosacral stenosis actually increases with age, and it is more commonly diagnosed in males than in females. For example, the incidence rate in German Shepherd dogs was found to be 33.7 cases per 10,000 dog years at risk, which is significantly higher than other breeds like the Labrador Retriever or the standard poodle. When these dogs are presented to a clinic, the majority have a history of caudal lumbar or lumbosacral pain. Owners may report difficulty rising, a reluctance to jump, or a low carriage of the tail. In some cases, working dogs may simply refuse to perform exercises they once mastered, such as jumping. A consistent finding during a clinical examination is pain evoked by pressure applied directly over the lumbosacral region. Clinicians often use specific tests, such as the lordosis test or tail hyperextension, to confirm the source of the pain. Some dogs may even display a nerve root signature, which is a non-weight-bearing pelvic limb lameness resulting from the entrapment of the 7th lumbar or first sacral nerves. While the preliminary diagnosis is based on the history and clinical findings, advanced imaging is essential to confirm the presence of degenerative lumbosacral stenosis. Conventional radiography can show findings like the collapse of the intervertebral disc space or ventral spondylosis, but normal radiographs do not exclude the disease. Computed tomography and magnetic resonance imaging have become the standard diagnostic tools, as they provide superior resolution of soft tissues and allow for a detailed assessment of disc herniation and ligamentous hypertrophy. Magnetic resonance imaging is particularly valuable for identifying the loss of water signal in the nucleus pulposus, which is a clear indicator of disc degeneration. Once a diagnosis is reached, conservative treatment may be attempted, involving nonsteroidal anti-inflammatory drugs, weight reduction, and modified exercise patterns. Epidural injections of corticosteroids have also shown improvement in about 79% of patients, provided they do not have significant neurologic deficits. However, surgical intervention is indicated when dogs are unresponsive to conservative management or when neurologic deficits are present. The primary surgical goal is to decompress the Cauda equina and free any entrapped nerve roots. Traditionally, this has been achieved through a dorsal laminectomy, where the caudal portion of the 7th lumbar lamina and the cranial portion of the first sacral lamina are removed. While this procedure is common, it may be extended with foraminotomy or discectomy to achieve full decompression. A significant challenge in these traditional approaches is addressing foraminal stenosis, which involves the compression of the nerve root within the intervertebral foramen. Foraminal stenosis has been reported to occur in 68% of dogs affected by degenerative lumbosacral stenosis. In 2007, a lateral approach for foraminotomy was described as a successful method to address these lesions, showing good to excellent outcomes in 95% of cases. However, this open procedure requires an extensive approach and can provide limited visualization, which increases the risk of incomplete decompression or accidental injury to the nerve. This brings us to the core of our deep dive, the emergence of biportal endoscopic foraminotomy. In human medicine, minimally invasive spinal surgery has gained tremendous traction because it improves the accuracy of decompression while reducing tissue trauma and postoperative morbidity. Endoscopic techniques offer a percutaneous approach that avoids the wide-open surgical exposure of traditional methods. These techniques can be categorized into three main systems: percutaneous full endoscopic systems, which use a single portal for both optics and instruments; microendoscopic systems, which use a rigid endoscope attached to a tubular retractor; and biportal endoscopic systems, which use separate portals for viewing and for the manipulation of instruments. The biportal concept is very similar to arthroscopic joint surgery, where one portal provides a continuous flow of saline and a clear view, while the second portal allows for the unrestricted use of surgical tools. Because the surgical view in biportal endoscopy is similar to that of conventional microscopic surgery, it is often more familiar to spinal surgeons and may have a shorter learning curve than single portal systems. Recent research has established a biportal endoscopic foraminotomy technique specifically for the canine 7th lumbar and first sacral neuroforamen using standard arthroscopic equipment. This is a crucial development because specialized spinal endoscopic equipment can be costly and is not always available to veterinary practitioners, whereas arthroscopic tools are more common. In a comprehensive study involving 18 canine cadaveric specimens, researchers compared biportal endoscopic foraminotomy with conventional open dorsolateral foraminotomy. They tested two types of endoscopes, a 3 mm 30-degree oblique arthroscope and a 1.9 mm 0-degree needle arthroscope. The study divided the procedure into several critical phases, starting with the establishment of the most efficient camera and instrument ports. They determined that a dorsal keyhole port at the base of the 7th lumbar transverse process and a caudal port at the cranial border of the sacroiliac junction were the most ergonomic. The biportal endoscopic procedure begins with the patient in sternal recumbency. The surgeon identifies key surgical landmarks such as the iliac wing and the dorsal spinous processes and uses fluoroscopic control to locate the base of the 7th lumbar transverse process. A small 1 cm stab incision is made to establish the keyhole port, and the arthroscope is inserted to visualize the bone. Sterile Ringer's lactate solution is continuously infused at a conservative pressure of 15 mm of mercury to expand the working space and maintain a clear view. A second stab incision is made for the caudal port, and the surgeon uses a switching stick technique to finalize the portal placement. Once the portals are ready, a power shaver is used for the debridement of soft tissues surrounding the neuroforamen until its boundaries are clearly identified. Foraminotomy is then initiated using round arthroscopic burrs moving in a craniodorsal direction to remove bone from the 7th lumbar transverse process and pedicle. The end point of the procedure is reached when the nerve root is completely free from any impingement and can be moved freely with a nerve hook. The results of this comparative study were impressive. Biportal endoscopic foraminotomy using the 3mm arthroscope provided significantly superior visualization of the nerve root and the middle zone of the neuroforamen compared to the traditional open approach. While the open dorsolateral foraminotomy was faster, likely due to the surgeon's familiarity with the technique, the endoscopic methods resulted in significantly smaller surgical incisions of about 10 millimeters. Most importantly, all procedures successfully enlarged the neuroforamen, but the biportal technique using the 3mm arthroscope resulted in the greatest volume increase, averaging an expansion of 81.3%. This greater enlargement was attributed to the superior visualization provided by telescopic magnification and the clarity of the underwater environment, which allowed for more precise and targeted bone removal in the cranial and dorsal regions of the foramen. The research also included a clinical proof of concept involving a 4-year-old mixed-breed dog suffering from right-sided foraminal stenosis and a history of chronic pain. This patient had previously shown only temporary improvement with conservative treatment. The dog underwent biportal endoscopic foraminotomy using the established 3mm arthroscope technique. During the surgery, anatomical landmarks and the nerve root were easily identified, and the nerve was successfully freed from adhesions and compression at the exit zone. The dog's recovery was remarkably swift. Just 6 hours after surgery, the patient was able to walk unsupported without signs of discomfort. By the next day, the dog was fully ambulatory and was discharged from the hospital. At a 6-month follow-up examination, the dog had resumed full functional activity with no recurrence of clinical signs, and follow-up magnetic resonance imaging showed a morphologically normal nerve root without the previously observed signal abnormalities. Despite these excellent results, the transition to biportal endoscopic techniques involves a learning curve. In human surgery, proficiency in endoscopic foraminotomy typically improves after about 20 cases, with surgical times eventually approaching those of open techniques. A similar trend was observed in the canine study, as operative times halved over the course of the research. For human surgeons, it takes approximately 24 cases to master the biportal technique, after which operation times and patient satisfaction levels stabilize. Challenges during the learning phase can include operating at the wrong vertebral level, incorrect landmark identification, or incorrect drilling directions. This emphasizes the absolute necessity of routine fluoroscopic confirmation and a deep understanding of three-dimensional anatomy. Furthermore, surgeons are advised to continue drilling as long as possible before using manual tools like a kerosene rongeur to minimize the risk of sharp nerve root injury. The benefits of the biportal system over a single portal system are noteworthy. Having separate portals for visualization and instrumentation allows for improved maneuverability and the use of conventional surgical tools, making the procedure more adaptable for various clinical scenarios. While there are at least 2 access ports, the incisions remain very small, which may reduce tissue trauma and facilitate faster rehabilitation or even outpatient treatment. In human endoscopic surgery, advanced techniques for hemostasis, such as radiofrequency ablation, are used to manage intraoperative bleeding, and similar tools are being evaluated for veterinary use to further improve the safety of the procedure. It is important to acknowledge that there are limitations to the current understanding of biportal endoscopic foraminotomy. The initial comparative study was performed on healthy cadaveric specimens, and the researchers noted that cases of advanced degenerative lumbosacral stenosis with significant fibrosis or radiculoneuritis might be more technically demanding. In clinical patients, chronic inflammation can lead to the development of hypertrophic soft tissues that reduce the available working space and complicate anatomical identification. Additionally, while macroscopic nerve root damage was not observed, the gold standard for assessing iatrogenic injury would be a histological examination, which was not possible in this study. Further in vivo studies on a larger cohort of clinical patients are needed to fully evaluate the long-term efficacy, safety, and potential complications of this technique. In summary, degenerative lumbosacral stenosis remains a significant challenge in veterinary orthopedics and neurology, but the development of biportal endoscopic foraminotomy offers a promising new horizon. This technique utilizes readily available arthroscopic equipment to provide superior visualization and effective decompression with significantly less soft tissue trauma than traditional open procedures. By minimizing invasiveness, we can hope for faster recovery times, reduced postoperative pain, and an overall better quality of life for our canine patients. As minimally invasive surgery continues to evolve, it is likely that these endoscopic procedures will become increasingly accessible to the veterinary practitioner and eventually become a mainstay of spinal care. Thank you for listening. The titles for the reference papers are in the video description. From VetMed Digest, where we keep minds inspired, hearts light, and tails wagging.